Thank you very much. I'm really excited to be here today and looking forward to teaching you a little bit about concussion. One of the best parts of my job that has happened this fall is we are the closest that we've been in the last 2 years to a normal year. We are churning and burning here in Boulder with a lot of concussions, so it's appropriate time for us to talk about this. So what I wanted to always start out with concussion is what on earth happened? And this is a little refresher because we haven't really talked about concussion because we've been so busy talking about COVID. But all the while COVID has been happening, concussions have still been happening as well. And so what we wanted to say is, gosh, what happened with concussion? These are just funny little graphics that we have. I never played baseball, football, or soccer. I grew up in the concussion era. And this is still true. Even though COVID seems to have taken the main spot on our front pages, people are still very concerned about concussion and what could happen to their kids when they're playing concussion in high-risk sports like ice hockey or rugby or football or even girls soccer. So we want to dispel a lot of these myths and make sure that you understand exactly what concussion is and what you need to be concerned with. So how did it all change? Funny little story for me. I remember when I was in med school, there were all these different grading scales. And I thought to myself, who on earth would ever want to take care of concussion? Well, turns out I would. So things got a lot easier for us, as you can see here in 2001. It was the first time that everyone got together in this huge interdisciplinary conference that was the International Consensus on Sport Concussion. And you can see each year it has changed. Well, the good news is, even though we had COVID, the update is coming. The sixth International Symposium for Consensus Statement for Sports Medicine for Concussion is happening. It just finished actually right now. So probably pretty soon in the spring we'll have new recommendations. But all of our discussion and understanding of sports concussion kind of comes out of this because there was such a need for some consensus. So it usually comes in that journal that you see there, which is the British Journal of Sports Medicine. And then this is the group that came up with, if you've ever heard of this, the SCAT form, which stands for the Sideline Concussion Assessment Tool. So this is a very busy slide, but I just want to highlight for you, what are we talking about? So this is sport-related concussion. So this is separate than military blast concussion or motor vehicle accident concussion. Those are much different. So we're going to focus on sport-related concussion. So it is a form of traumatic brain injury. It's transient and it's immediate, okay? These expert consensus guidelines will change wording here and there, but I've highlighted the most important things on this slide. It's a biomechanical mechanism, okay? And it can happen either by direct trauma or even a head injury that creates whiplash. So it doesn't have to always be something where you've hit your head. And then it's rapid onset of short-lived impairment. In addition to that, usually it will resolve spontaneously, and sometimes in just a couple of days even. And then the biggest thing is it may or may not involve loss of consciousness, which for a lot of people is very different because they think that it always has to have loss of consciousness. So, and then the last part, which is particularly important when you work on a college campus and when you work with children, is that these symptoms can't be explained by use of any medications, drugs, or alcohol. So this has to be issues that are separated out from other distracting injuries as well. So that's kind of our consensus statement in some ways of what a concussion is. Initially, when we first did the consensus statement, it was it simple or complex based on whether or not you lost consciousness, but that's not the case anymore. It's just, which makes our job significantly easier. One of the biggest things that we get as a question is, what grading would you give this? And in my world in sports medicine, as soon as I tell a student athlete or someone that's athletic or busy doing athletic activities, if their concussion is mild, moderate, severe, the next question in my line of work is, so when do I get back? And that's not something that we can predict because it's different for every person. We have a saying in concussion care that once you've seen one concussion, you've seen one concussion. So it's much easier now. It's just, do you have a concussion or not? That's all we need to figure out. But the reality is depending on the study that you look at, is that most concussions, anywhere from 86 to sometimes even 93% of concussions, can get better in 7 to 10 days without doing anything, with just resting and modifying your activity. Now, kids, different. 18 and under, their brains are different, and sometimes it can take longer, sometimes up to like 3 to 4 weeks. But there's nothing magical that happens in a college kid. So sometimes their brains at 18 and 21 look like a kid, and sometimes they look like an adult. But that's reassuring news. That's a reassuring slide. Oops, wait, I went too fast. This is one of my favorite pictures. bell-shaped curve before COVID, when we heard much more about concussion in the news. Really, the majority of what you were reading about was probably not true. The truth is in short supply. So my goal tonight is to educate you on what the truth is so that you really know what we're talking about. So I love to go through this. I've kind of stolen a little bit of thunder because I told you about the consensus statement, but I really want you to know these things. So what's the myth? You have to hit your head, right? Yeah, right? You have to hit your head? Is that true? No, it's not. It's false, right? You don't have to hit your head. Every season, every football season, every competitive season we go through, there's a kid that may have jostled their head around, not hit their head, but got a whiplash mechanism of injury and sustained a concussion, but they're not sure. So you have to be careful. When kids get, or anyone gets a whiplash, you have to be mindful of the fact that they could also have concussion as well. This one's a big one, CT scanner and MRI to diagnose a concussion. I always say the same thing. I remember years and years ago when Hillary Clinton got her concussion, they came on, I think, NBC News or something and said, great news, Hillary Clinton got cleared today from her concussion because she had a negative CT scan. And all the sports medicine doctors went like this. No, you can't see a concussion. You cannot see anything that is a structural abnormality on a CT scanner or an MRI. So that is a myth. It is a functional disturbance. So it's massive functional disturbance for the person's brain. So it's not something that you can see on anything that we can use yet clinically that is helpful. Okay, man, here's a big one. If you lose consciousness, man, you're up the creek. Like, you have a really big problem. That's got to be true, right? Actually, no, it's not. So the majority of concussions are going to happen without the loss of consciousness. I'm not saying that loss of consciousness is not important, but we look more at the duration of how long someone has been out. When we start to get like to more than 5 minutes out, then we start to worry a little bit more. Interestingly enough, some of the worst concussions in my career that I've seen, no loss of consciousness at all. Here's one of my favorites. This is not to say that this research won't continue to happen, and that's important because it absolutely is. Helmets and soccer bands prevent concussion, right? Isn't that true? Remember the soccer bands came out, right? Everybody wants to wear them, prevent concussion. I hate to tell you. If that was true, then our ice hockey players and our football players, and when we ski up in those mountains behind me, you wouldn't get concussion, right? Because we have a helmet on. And so for those of you that have ever seen the movie with Will Smith about concussion, he talks about the woodpecker analogy, about how the woodpecker can peck, peck, peck and not get a concussion. Our brain and our central nervous system, and it's combined with our spinal cord, and it floats in water. It floats in cerebral spinal fluid. So the concussion mechanism happens when our own brain, because of inertia, hits into the inside of our skull. So until we can figure out a way to pad internally, these are helpful because they're going to prevent you from getting a skull fracture or a brain bleed, which will kill you. So these kind of devices are still important, but not as great as we wish they would be for preventing concussion. Okay, this one is very important from my perspective. When you have the luxury like I do of taking care of a lot of people from a lot of different areas of the country, a lot of different areas, even in the state, even in this county even, I don't know where this comes from, but once you've had a headache with concussion, that once your headache is gone, you can go back to play, right? No. So what if your main symptom was dizziness and you never even really had a headache, okay? There's a huge list of symptoms, and so this is absolutely false and should not be used as a criteria for return to activity. The next one is, this one is the one I'm most passionate about. I can't tell you how many people I've seen that say, well, there's nothing to do about a concussion, so I just sat home. And then you see them like weeks, months, sometimes even years later, and you wish that they would have come in. This is not true. And especially now with our evolving research that we have that's happening, one of the biggest changes is we have an active role with rehab for concussion. So managing concussion is active rehabilitation. When you give this as a nugget and you teach people this, it gives coaches, it gives athletes, it gives teachers, it gives everyone more hope. It's not just sit in a dark room and wait for something miraculous to happen. There's something you can actually do for it. Hot topic, right? This one, concussion causes CTE. So that's what the movie Concussion was all about. That's what you hear about. And at this point in time, there is no definitive causation relationship where A plus B equals C, that multiple concussions or one concussion causes CTE. CTE is real. I'm not saying it's not real, but this creates panic, right? And so we're always talking about risk benefit. Would we rather teach our kids and teach our young people, teach all of us how to exercise healthy, work with good coaches, work in good environments, or have them do nothing because we're afraid that a head injury could cause CTE? I think that that's not what we want. So this is just the concussion 101 right there. It's the most common injury in sports by far, no question. But like we said, it's shearing, it's twisting, it's inertia, it's a lot of physics. And it changes, this is, if you remember one thing, hopefully from tonight, concussion is about changing the way your brain works, the way it functions, it's a functional disturbance. May or may not, like I said, loss of consciousness, right? And it has a wide severity. So if you're watching Monday Night Football, yes, it is possible that in some of those kids or some of those athletes in a week, they could get back to play. It is possible. But then someone else could sustain a concussion. It could take them weeks to get back. So once you've seen one concussion, you've seen one concussion. And it can happen in practice and it can happen in competition. This gets, at the idea of how the brain is functioning and how it's hitting. We don't necessarily, you can't always say if I hit here that the brain ricocheted and hit in my back. So there's a lot of things having to do with it, but this just gives you a visual of what we're talking about how that brain is kind of moving in the cerebrospinal fluid. I put a bunch of different graphics in here so that you could understand how difficult concussion is. It's what we call a clinical syndrome. So there's evolution of science and things looking for blood tests and things like that we could say would be diagnostic to tell us if we have a concussion or not. But really, this is a symptom-based clinical syndrome. So this particular slide breaks up some of the symptoms that you would have into somatic, cognitive, emotional, physical, behavioral, another cognitive impairment, and sleep disturbance. It's a wide variety. So my joke for you is, but it's true, if you have children, and especially if you have teenage children, how do you tell when you look at this that this child that potentially had a head injury isn't just acting like a normal teenager, right? So they have a headache, they had a long day, school's been hard, transitioned back to school from COVID, maybe they broke up with their first girlfriend, boyfriend, and they're having a bad day and they're mad at their brother or their sister, right? They could look like this. So how do you tell? Right? It's very difficult. One of my favorites years ago was one of a soccer player. And I asked her the day that I cleared her for her concussion to go back to sport, why are you still grading like 5 on your irritability? She said, I'm a teenager and I have siblings. She wasn't concussed anymore. So every time you see these patients, it's individualized, their management. This is a visual for you of just some of the things of what they might look like. And so it's just important for you to know that the symptomatology is really varied and its recognition is really important. Again, probably one of my all-time favorite slides, pictures of concussion. Back to the initial thing that I said when I was in med school, oh my gosh, who would want to do this? I think this is why I like this. When we look at the brain and all the different things that can cause the symptoms related to concussion, this is a perfect picture because it's all of this potentially, right? It's vestibular, which has to do with where you are in space inside your ear. It's my eyes, it's headache, it's all kinds of things. It's emotional, it's cognition, it's the neck. It's really everything. And the art of concussion management is understanding that it's all those things and how they intertwine. But I love this picture. Maybe it's like a love-hate relationship with it. I don't know. But it's very accurate. Okay, so what do you do? Right? What do you do if you suspect a concussion? So the most important thing I would say is identify it, right? Like it's rapid, it's pretty quick. Now I will say that sometimes concussive symptoms evolve and you don't always know. Sometimes on the sideline, I pull somebody and I'm sitting and I'm watching them because I don't even know, right? I'm just watching them. What you don't want to do is ask them who's the president of the United States and what's the date today. Ask them things about the event, right? So if they're at a ski race, what mountain are we on? If you're in a soccer game, what play were you running? Who are we playing against? Things that are pertinent to the situation, right? If they don't know what quarter it is and they don't know who they're playing or what they're doing there, that's a red flag, right? So in other words, they might know who the president is. They might know where they go to school. They might know who their parents are and their birth date. But they might be completely clueless when you talk about the things that are pertinent in that situation. Those are called Maddox questions. This is important. Don't leave the athlete alone, right? These are not reliable injuries because they can decompensate. And the fear is, right, what if it's not a concussion? What if it's a skull fracture? What if it's a brain bleed? So these are things we don't want to leave them alone. Plus, they're not reliable. They can't remember anything. There are times when I walk into a room and I stand at the doorway and I can look and I'm like, okay, that kid's not going to be doing anything for the next couple of days. So you can't let them be alone because they're not reliable. You have to watch them. But here's the big thing, right? If you suspect concussion, you've got to pull them from play. The medical legal responsibility has extended far beyond now just us, right? For coaches, there's a higher medical legal responsibility that the CDC, I'll show you in a little bit, came up with this saying, when in doubt, sit them out, pull them. And these are hard decisions, but it's the right thing to do because you get one brain, just one. So this is it. When in doubt, sit them out. It was a wonderful little catchphrase that the CDC came up with. I can't tell you how important this is. It happened, whether it's the last play of the game and playoffs. I mean, you can't afford to make a mistake on this. We've had fights with referees before in the past for an opposing team. We're saying, no, I know I'm not their team physician, but it's not safe. We're going to talk about why that is in a little bit. But when in doubt, sit it out. That would be another thing I would say remember from this lecture. So another thing, so if you suspect it, then they need to go get evaluated. That's important. They need to get an evaluation by their family medicine doctor, their pediatrician, their internist, or just at least someone. If you go to the urgent care or the ER, they can give you a diagnosis of concussion. But remember, the expectation is not fair to put on the ER or the urgent care for definitive management of concussion. I cannot emphasize this enough. Concussion is an outpatient diagnosis, which means you're going to the ER because the person that you're concerned with, you're worried that they could have a brain bleed. Could they have a skull fracture? Could they have something that is really bad? So when you leave that ER, the concussion, with a concussion diagnosis, it's not their responsibility to help you to get back to play. You've got to have follow-up, and that's really important. So definitive management has to be as an outpatient. And now I put this as a caveat because I'm going to teach you tonight about how lucky we all are to be in Boulder because of a really unique program that we have here in Boulder. In general, more and more evidence is saying sometimes, yes, there's a couple days kiddos have to stay home from school, you have to stay home from work, but don't have them sitting out for weeks and weeks on end just waiting for something to get better, especially not in this district, and I'll tell you why. So we're going to talk about the difference between return to learn and return to play tonight, right? And so even what if like you're watching tonight and like you're in California or something, find out what your school district's concussion policy is. And if they don't have one, then we can talk about that. So key points on this slide, please don't put it on the ER and the urgent care to manage the concussion. They're there to we need to respect what they're there for. They're there to make sure you don't die, right? That there's not something really bad happening. Concussion outpatient diagnosis, please don't show up at the urgent care or the ER and ask an ER doctor or an urgent care doctor to help them get back to play. That's not their job. That's not what they're trained in, okay? So, and then we're gonna talk about this, why we're so fortunate to live in this district. This is the SCAT, which I was telling you before. The cool thing about this is this was a tool that was made for us to help us make sideline decisions. The most recent international consensus statement gave us a kid version as well. The new one is very exciting. We're gonna get a version for the office, which is great, because this was really made for the sideline. But I just want you to know what SCAT is in case you hear. Okay, when do you worry? I promised you we would talk about this. Like I said, loss of consciousness, transient, that's really not indicative of the severity of a concussion. When someone's out for a longer period of time, like 5 minutes, as I'm sitting on the football field holding someone's head and I'm assessing what we need to do, this is getting me more and more nervous the longer they're out. Distracting injuries, this is really important, any of you that know trauma. So if every year before school starts, we practice with all of our athletic trainers, we go through different catastrophic injuries, right? So the worst one being someone falls on the football field, they dislocate their shoulder, break something, but they also have loss of consciousness and a potential head and neck injury. So when you have a distracting injury, you are not a reliable patient, right? So you may have a head injury or a neck injury, but the distraction of your shoulder dislocation is going to skew things. So be careful with that. Repetitive vomiting. So people will vomit with concussion, no doubt. But it's when it's vomiting over and over again that we need to be worried about. Classic, worst headache of my life. This may be true, but if it's really bad and you can't control it, that does need to go because it could be something worse. If they're unresponsive, they got to go. And then rapid decline of consciousness. This is why you watch them. So if they're doing okay, and then all of a sudden I turn around and on that sideline, I see this kid slump down, I'm in trouble. He's got to go. Okay. And then they're difficult to arouse. Please let them sleep. It's okay. But if you are really having a hard time getting them up, then that's something that we need to look into. Okay. I need help on this one. I'm going to narrate this. So as she mentioned, I'm a very blessed person. I get to travel with these wonderful people throughout the world for Team USA. And this happened last year at the World Championships. And this particular video is good. If you've never seen what a concussion looks like, this shows you. So you can, if you can, hopefully, I keep my fingers crossed it works. So this is pair skating. Can you turn your mic down or no? Okay, great. Thank you. Thank you. So what you're going to see here is Ashley's having a hard time. And Ashley had actually already had a really tough time the year before with another head injury. But these are not concussive injuries, okay? Coming up here, you're going to see something not so good. Bam. She hits her head very forcefully on the ice. Notice her posture as she's lying there. That's actually her mom. That's her coach. But you're seeing her lay on the ice in a very bad position. She's limp, right? She's a limp dish rag. Here's slow motion. Turn away if this gives you the willies. So the ice is hard. Look at her legs flop right now. She's gonna hold her head. This flopped position is not good, right? So this could be anything. Like this could be even something like a brain bleed here. What's nice about this particular video is that Ashley gets up on her own. Tim doesn't take her by the head. Look at her face. You'll see her face in a second here. That's a concussion face. She's confused. She has no idea what happened. She's stunned. That's my friend, Dr. Fred Workman, and my French doctor friend that's out there. And so if you've never seen what a concussion looks like, this was unique because not only is this a group that I'm relatively close with, but the camera lens on this did a really good job of showing you what concussion looks like. So the flopped position, limp as a dish rag, stunned, she's holding her head. Those are all signs and symptoms. And thankfully in this case, she got up and she did not have loss of consciousness. Okay, so that's what a concussion looks like, and that's when we worry. Good, okay. I think, let's see. Gotta try to get this thing to advance. There we go. Did I get it right? Let's see. Yeah, okay, we did that. Good, okay, great. Wonderful. Videos always scare me when I put them in. So for you on the sideline, if you don't have an athletic trainer, which is the best thing we could all do is make sure that athletic trainers are in every school across the state. Even if you don't have a team physician, having an athletic trainer is invaluable. When in doubt, sit them out, like I said before. Ask those sport-specific questions, learn these signs and symptoms, learn what it looks like that video is pretty dramatic, and then err on the side of caution, right? Okay, this took shape over the last several years more assertively, and I really need to comment on this. So in 2001, if you think back to my original slide, when this all started, it was all about brain rest, right? Like shut them down. By the time 2009 kind of came around, 2010, we realized this probably wasn't a great idea because think about who's getting these concussions. This is sport-related concussion. So we're taking these kids and we're saying, sit, pull yourself away from your peers, don't do anything. Then we started to see kids get secondary anxiety and depression. So research, what we do is evolving. And so, yes, there is a time frame that they do need to shut it down. But we've moved past and we're better at managing concussion. There is a time and a place for turning down lights, the backlight, not looking at screens, these crazy devices that everybody's on, right? There is a role for that, no doubt whatsoever. But what you're gonna start to see is that maybe in the first week we'll say, yeah, go ahead, go for a walk, right? Or maybe you can get on your bike a little bit, you're on your stationary bike. So I cannot emphasize this enough. Each concussion is different. So when you hear that your friend went to the ER and was told they can do whatever they want, please, it's got to be individualized. So like I said, some kids I'll get into the room and they look terrible and they feel awful. They've got to shut it down for like 2-3 days and they even have to miss school. So this treatment has to be individualized. Are we more active and are we more involved than we used to be? Yes. Are we moving the pendulum? Yes. But it still needs to be individualized. So there may be a time frame where you need both physical and cognitive rest. But as a student, we're going to swing into this. We have return to learn. And return to learn doesn't get as much focus as return to play. And that's what we're going to talk about now. So return to learn, right, for most of us. And let's be honest, I don't want this presentation to come across on like it's totally biased towards students. Obviously, this is a huge proportion, but there are those of us that do work that get concussions. And so you can basically say return to learn is like return to work too. Except for the fact that in return to learn in school, I can write you a note and say, hey, this person needs extra time and they're not reliant on a boss, right? A little trickier when we're adults and we have someone that we have to report to. But either way, it's the same concept. It's cognitive exertion. So in this case, if the student tells you that they are exhausted at the end of the day and they feel terrible, they are not being adequately supported in the school day. This is the thing. She mentioned I covered Chicago Marathon. I've seen someone break their femur at mile 18 of the Chicago Marathon, finish the marathon, end up in my medical tent, and go directly from the medical tent to the hospital to get pinned. So there's a lot of things in sports medicine we can push through. You cannot push through concussion. It is not possible because eventually concussion proves itself. So you'll get rebound effect. And then you guys get to ride the concussion roller coaster. That's not a roller coaster you want to be on. So you need formal clearance for return to play, but you have to get help. Like, don't try to manage this from home. It's just too difficult. Most of the time, we will find that when we get kids back to activity like school and they get the academic adjustments that they need, they're gonna do better. But before they return to play, they've got to have all their symptoms resolved. So this gets to why why I in particular feel very blessed to live here in Boulder. 9 years ago, we created a partnership. Back when we were Boulder Center for Sports Medicine, and we were in partnership with Boulder Valley School District, with us having the medical responsibility for the students and the Boulder Valley School District, of course, having the academic responsibility for the students. And we came up with our district-wide policy that has been really wonderful and talking about return to learn and formalizing something. Return to play has been around since 2001, since we first started the international consensus. But what is return to learn? So we had this partnership. We put all these things together, right? That was when we first started, and then our new center that we built 7 years ago, Boulder Valley School District, and we came up with this, the Boulder Valley School District Brain Injury Resource Team. These are just some of the wonderful people, including many BCH employees, who have been part of making this program possible, including our wonderful nurses and two of our nurses that have head up this committee in Boulder Valley School District. And so all this work I'm going to present to you now would not be possible without these folks and many others. I have listed for you, in case you don't know, in Boulder Valley School District, we have a team physician that's assigned to each school, as well as an athletic trainer. I'm the director of outreach at our center, so I watch over this program. And we have an athletic trainer that is there to cover all varsity sports as well. So if you didn't know that you had an athletic trainer at your high school, and you didn't know that you had a team physician, there they are. So we learned quickly that we had to understand, if we're going to help the school district, how do we translate medicine into education? This is interesting to me. I'm married to a teacher. It's a different language, right? So what we talked about are the concussive symptoms, and then you'll see on the other side, how in academics, how does a teacher, this is a teacher word, differentiate to the concussive symptoms in the schoolroom? Okay, so this is a good slide. So these are all things I learned from my academic school colleagues that were really important when we were writing our return to learn policy. Academic adjustments. They want us to use this word instead of modifications. Differentiation. So for those of you who teach, you know what this means. I mean, just like a kid who has ADHD or has dyslexia needs to be differentiated to, right? A concussion patient, concussion student needs to have differentiation as well. So teachers know how to do this, but we just had to translate for them, how do they do this? A 504 is different than an IEP. So 504 is a little bit less specific and higher demand than an IEP. 504s can go with you through many different parts of your school life, from high school even into college. Like here at CU, we have kids that have 504s. These are things for like anxiety or depression or ADHD or seizures, you name it. But a 504 plan is not part of special education. It serves a different purpose. So these were all terminologies and things I had to learn as we were medically understanding how to make concussion something that was palpable and easy to digest in the schools. So this shows you our Boulder Valley School District concussion program. We've always said that this is a program that is not exclusive to us. If anyone doesn't have a program, we're always happy to go out and talk with them, whether it's myself or our nurses, because this is for the overall benefit of children. The biggest thing that was wonderful about this is that this is a program that is for all Boulder Valley School District kids from kindergarten all the way through senior. So you don't have to be a varsity athlete. So the healthcare provider first makes a diagnosis of the concussion, fills out the form that I'm going to show you just in a second. And all of a sudden, there's a flag that goes on that kid's chart in Infinite Campus that says, hey, this kiddo got a concussion. So if the kid's not acting right, you can go and see why, right? And then emails are sent to the teachers. So the teachers know that this kid's got a concussion, right? And then there's tools and support systems that go out for the teachers to figure out what to do for the kiddo. Super huge. They get put on concussion protocol. And again, this is differentiated for the needs of each student. So what they might need in math may look different than what they need in science, and that's okay. The bottom line is we don't want kids penalized for having a concussion. It's not their fault. So different needs for different levels we found out too. So what we can do in elementary school versus middle school and high school is completely different. In high school, we have the luxury of having our athletic trainer who can be really involved as well. And then we have special considerations for sometimes we have to talk about too. So we took the form and we consolidate. It doesn't project super great, but if you haven't seen this, this is a form that we use to make it easy. The first part of the form is if the concussion was observed by, like, let's say an athletic trainer. The athletic trainer fills this out. You take this to the doctor. Doctor has a bird's eye view of what happened. The next part is the return to learn. All we ask providers to do, and this was education for me. So, and again, my husband taught me more about like what happens when your teacher and a doctor writes a bad note. So once a doctor writes a note saying what a kid needs, the school has to follow it. So we were actually hamstringing students by saying that a student had a concussion, they can't take tests for 2 weeks. What if they're fine to take their math test, but they can't take their Spanish test? You're creating more burden for them. So because we got a grant to do this, and because we've been able to do this at such a high level, on this form it says, just does the student have a concussion or not? Just that's all we need to know. Don't write anything else. And underneath it says academic adjustments to be determined by school staff. And so then the kid can go back to school, and the teachers, the people that are with them every day, can start to help them, which is huge. And then the next one is the return to play. Can they go or can they not? And this applies to physical education as well. So we just try to make it simple, simple, simple. So that's the form that we have. So then once the student is on the concussion protocol, we have another tool that I'm going to show you that we made. This has been really important because the students told us, hey, Dr. B, it's great we have this concussion policy, but the work is piling up here and I'm down here, and this is freaking me out. So we have a teacher feedback form that the student can take around to each of their teachers, and they can fill out information and have a conversation with their teacher. There's nothing like a student having a conversation with their teacher about the specific needs that they have. So we realized that needed to happen, and that frequent revisiting needed to happen for them. So, and then they do need regular follow-up at a physician's office as they're navigating through this. Again, this is an outpatient diagnosis. Now, this is interesting, step 5. The teachers, this is not in the evidence, okay? So this is not in the published journals for concussion. This was something our teachers in Boulder Valley School District said to us. They said, at 3 weeks, if a kid is still struggling and hasn't made enough improvement, we need you to help us make some decisions, right? So like they can, in other words, differentiate for about 3 weeks or so, but then they need to know like what direction we're going. So how much longer does the kid need to be on concussion protocol? Or do we need to look at maybe this kid needs a longer period of time? Maybe the kid doesn't need a 504. So that was educational for me, just as thinking about how we educate. So for any of you that are physicians or healthcare providers, that's not in any kind of medical journal. It's something that we got direct feedback from our district of what our teachers needed. So if they're doing great though, and they can start return to sports, gradual return to play, and they can go back to PE as well. So they get signed off for that. And our policy is 2 steps, right? Go to the doctor at least twice, right? To say you got concussion or not, and then to get cleared to go back to school, right? And then to get cleared again for return to play. Return to learn, return to play, different things, right? Return to play means if you're not completely asymptomatic from your concussion and you get hit again, you could be in trouble. If you're doing too much in school, you're not going to get hit in school again, right? So your risk is lower with return to learn than return to play. And then again, based on where you're at, you may or may not be able to, in the return to play process, have an athletic trainer that's helping you with that. This is that teacher feedback form I mentioned. It gives the student an opportunity to take a piece of paper as a reminder to go talk to their teachers. It can be super helpful. Okay. So let's say the student starts their return to play process. The athletic trainer can be working with them to get them back. But if there's not an athletic trainer present, then somebody might need to instruct, whether it's a physician or coach potentially. And PE or PE teachers understand what this looks like. And it's basically, I'm going to show you in a second, it's increasing the load on that person every day. So then the next part is then you get full return to play, no complications, you're great, you're good, see you later, keep having fun. If they are unable to play, so step 8B, without their symptoms progressing, then we have to come back and reassess. And we have to say, okay, what's their rate limiting step? If their eyes come back online, like what's going on? So then in that case, they might need physical therapy or a bunch of the other things that we do to help them get better if the concussion recovery has become protracted. So again, here's translating medicine into education again. So let's say I have these symptoms of the headache, vision changes, and all that. What are the things that I could do? So if I have headache or vision changes, I may need to go to vision therapy. We're very fortunate at our office because we have a concussion team. So our physical therapists are able to do eye therapy in tandem with their other therapy that they're doing. Maybe I had pre-existing psychiatric issues, okay? Lo and behold, right, we're gonna see kids that have pre-existing ADHD and anxiety and depression. So maybe there may need to be some medications that are changed or even taken away. We might exacerbate those pre-existing psychiatric conditions. So dyslexia can become exacerbated, so we might need cognitive therapy. So there's a lot of things that go into it. Neuropsychological evaluation may come in that we might find because of the concussion, a new learning disability. So the overall here is when we are looking for things that are stalled, we may need to involve some of our other team members, which is really important to know. Again, this is an active recovery, right? So one of the reasons I love sports medicine so much is it's not about me. And what I mean by that, I don't do anything without a team. And there's a team at the school, and there's a medical team too. And so this is the consummate, I believe, sports medicine diagnosis, because it's about a team, and it's about involving everybody to get this person better. And this is just a glimpse of what that may look like. This is a great one. If you're looking for a slide to come back to, we have learned through the years that concussion doesn't matter until it matters. This is maybe one of the most important slides in the whole talk, because this is just a glimpse of what different academic adjustments are for kids or people that are having problems doing what they need to do with concussion. We have the list is much, much longer than this, but this is just a smattering of some of the things. But this is a huge slide. And you can see there's all kinds of things that we can do, right? This is not just sit in the dark and wait for something to happen. This one's important. So we did spend time making sure, and this is relevant, and these are proven in the literature. There are pre-existing conditions that can exacerbate concussion or make concussion more difficult to manage. So if you come see me for the first time, we're going to go through all these things and ask all these silly questions. But this list up there are some of the things that are correlated with a concussion that's more difficult to manage. So pre-existing history of psychiatric disease, huge. Sometimes pre-existing history of migraine, huge. So this is a list of all the kinds of things that can make the concussion more difficult to manage. So when I see someone and we're looking at someone and I'm stratifying the first time, maybe they have a lot of these things, but maybe they're going to do fine with this concussion, but the next one they might not. So you're always thinking about that holistic kind of evaluation of your patient. Helpful hints for you. The reality is that people may not recognize their previous concussions. And as much as we wish that they would, they may not. They may have previous head injuries that they didn't think were concussions, or places where they didn't get back to normal. So that's important. So one of the critical questions I ask in history, it's all about the history. This diagnosis is heavy history. Is after you had your head injuries or concussions, did you get back to baseline? Did you really? Or did all of a sudden you couldn't read as well, or math was more difficult? These are important things I want to know. Coaches and teammates, people in the situation may have great information, but they may not too. So you have to kind of pick and choose how much you're relying on the history of others, but it can be really helpful. But at the same time, there's a lot going on in situations. They may or may not have an accurate description. Remember, you don't always have to hit your head, right? So previous facial injuries, neck injuries, back injuries, those are all things that we want to know about too. Do you think you got a concussion with that? I don't know. No matter how much time we spend educating, no matter how much reassurance we give, these last two things are still the case. People are afraid to get removed from sport. I've had people close to me and be like, I didn't want to tell you I hit my head, because they're afraid I'm going to tell them they have a concussion, right? But you can hit your head and not have a concussion. It is possible, but it's still a stigma. And we know that athletes underreport symptoms, and that's because they're afraid of removal from their game, their sport, what they want to do. So we're always fighting that. And the best way we can do that is with education. This is an example. I put two slides in here of this. This comes from the actual consensus paper, the international consensus, and it's the stages of gradual return to play. And you can see that first you have symptom limited activity. So you're just doing very, very simple things that don't provoke activity. And then in addition to that, the next step is this light aerobic exercise. So it's very possible that in the first visit, I'll be coaching you that you're going to be doing stage 1 and 2, right? We're going to let you do a little exercise, right? But when it gets to you going on your own, and I'm a basketball player and I'm just going to be at my house and I'm going to do some bouncing and some shooting on my own, then we're starting to move in that stage 3, right? Then we go to non-contact practice with our friends or with our teammates. So no one can box me out, no one can do anything like that. And each step has to have 24 hours in between so you can see if you've had symptom provocation. If you're doing okay, then you get to go to full contact practice, and then you get to go to a game. And the idea here is every day you're adding more and more to the nervous system to see if you can tolerate it. If you get symptoms at any one of these places, you stop until you can navigate that step appropriately. And this is very helpful because this is where we catch things sometimes. This is an example, same kind of thing, but it just shows you more sport-specific things. So like in this one, it says sport-specific exercise, skating drills for ice hockey, right? Just by yourself. Running drills in soccer, no heading, right? So we take the gradual return to play program and we customize it for whatever activity you're doing. Skiing, like right now we're in winter sports, right? And fall sports have finished. So you're trying to really make this customized for the person that you're doing this with. Okay, so now switch gears. So let's say we've decided, right, that this person needs some extra help in physical therapy. What on earth do we do? I love to talk about this because this dispels that myth. There's nothing you can do for concussion. So you see we have three pictures there, the musculoskeletal system, ocular motor system, and then also the vestibular system. So these are some of my favorite systems to talk about. So in physical therapy, one of the most common things that you'll see that most physical therapists can do, even if they don't know concussion, is you can treat the neck. You can treat the upper back, the thoracic area, and you really do it based on symptoms-based findings. So if you had a whiplash mechanism, you're gonna be working on their neck. I would tell you, maybe not 99%, but 90% of people are gonna have neck stuff with concussion. And the way I describe it, it's like our big cottonwoods that we have, the wind comes whipping down like Boulder Canyon, right? And you see all of the leaves are moving, right? And so that's like the brain movement, but you have to have a stem, right? And the stem is the neck, and the stem is also moving too. So majority of time, treating your neck is really important and your upper back is really important in concussion. And that's one of the things that we do with physical therapy. The vestibular system. This is our awareness of where we are in head and space. So this is important. This is not traditional vertigo, right? So like kids don't get vertigo. Adults, we may, right? You get sick, you get like an infection and you get like, whoa, I've got vertigo. This is different. Your vestibular system is buried deep in here. And the vestibular system is a major contributing factor to issues that happen with concussion. So we can work on that. And we integrate our position, our head and neck in space, our eyes as well. This is a huge part of concussion rehab. Now, that's also combined vestibular and oculomotor. One of the newest and the greatest things and the most fun, and when our physical therapists say that patients get a smile on their face, they don't have a smile when they see me. They have a smile when they see the physical therapist because the physical therapists are letting do more and more. It's exertional testing. So that's Dr. Letty, wonderful human. And he came out around that like 2009, 2010 and say, what are we doing with this brain rest? So he had a bunch of college athletes that he could say, hey, let's push on a treadmill right after you got this concussion. Let's see, do you really get worse? And if you do, what happens? And this was the beginning of letting people to start to be a little bit more active. So we talk about sub-threshold exercise. We get them functional. We get them doing all kinds of things to start rebuilding the complex layers of your nervous system. This is super fun. And this is really important to do. This is where concussion is going. So this is a smattering of some of the sport-specific things that we will do as we're getting somebody back. On the bottom, you'll see our flume, which is at the Sports Medicine Center, which has been absolutely amazing with the work that we've been able to do using the pool, especially when you have athletes here in Colorado that spin, jump, twist, and turn at very high, fast paces. So half pipers and skiers, right? If someone, or a parkour athlete or a rock climber, how are you gonna get somebody to flip and practice their sport when they've had a concussion and they don't feel comfortable with where they are in space? You put them in the water. So we do all these kind of really innovative things. And again, customizing everything for what that person needs to do. So this is the active role for concussion rehab. Okay, I'm almost done. I couldn't do a talk about concussion without talking about baseline testing. This has been everywhere, okay, since we started doing this. And I wanted to talk about this because there was a time frame where this was like supposed to be the end all beat all. This was like the thing, right? Everybody's gonna, baseline testing is gonna be great. Well, not so much. So there's definitely a role for baseline testing, and whether that's computerized testing or coming in and talking with a doctor and working on like what your risk factors are, it's just part of the equation, okay? There's a large variability in testing. Ideally, you want them symptom-free to do a true baseline, but it's just part of it. This was mostly focused on cognition, but there's so many other things, as you could see from one of my favorite pictures, about what is involved with concussion. So if you're looking for baseline testing or you want to do computer testing, please just know it's just a part of the picture, and this is not the sole decision of getting somebody back to play. If you do it too often, too, there is a learning effect as well. So this this is not as popular as it used to be. It's still important, and we still do use it, right, in our high-level sports, but it's not the end-all be-all. It's not perfect. This is just one of the systems that you'll see impact. I guess the other thing I would say is please don't fall into the idea that like if you do one of these tests that it makes you safer, because unless you have someone that knows how to interpret this test, it's a computer test. And so you need to be able to know how to interpret this test. So paying X, Y, and Z money to go take a baseline test doesn't mean anything if you don't have someone interpreting what this information means, and making sure that the test is done correctly. So I'm not saying it's worthless, but it's just part of the picture. Okay, so I couldn't talk about concussion without talking about this. My pet peeve. So post-concussive syndrome does not have a good terminology. It carries stigma. It makes people feel depressed. It makes them feel like they're never going to get better. It's kind of a bucket term, I call it, for people that haven't gotten better within like 3 to 4 months of their concussion. But the reality is if you've reached that point, then we got to dive in. We've got to get dirty, and we've got to pilfer through all of the issues and find out, did someone just not recognize your vestibular dysfunction? Do you have ocular motor dysfunction that hasn't been identified? What's going on that's causing your concussion recovery to be protracted? And this is where we talk about neuropsych testing, physical therapy, all those different things that are up on that side. So I really can't emphasize this enough. It's important because it means something to you guys as patients. You don't leave the ER or the urgent care with post-concussive syndrome. You're concussed. You're actively concussed. You feel crappy, okay? So post-concussive syndrome, I just want to make sure that you understand that that is something that we just use as a terminology when someone's not getting better. But you really need to dig into that and try to understand why someone has that and why they're not getting better. This is the reason we have laws in all 50 states. And this is why the CDC came out with when in doubt, sit them out. Second impact syndrome is something that is very rare that we don't really know that much about. But in our state, it was Jake Snakenberg, and you can look it up, and that's our law that we have. And so for him, it was 2 rapid football concussions back to back. So what happens is you get a concussion and you keep playing, and then you get another hit. And we don't know why, but it's total sudden collapse of the nervous system, and that leads to death. So this is why this is a risky diagnosis. And this is why if you're symptomatic, we can't let you go back to play. And that's why these laws exist. So if you ever run into a situation where someone's fighting you and saying, no, this person needs to stay into play, it's a law. So it even trumps me as a physician. This is a law. If there's a suspect concussion, they need to come out. And this is the reason why. So where do we go from here? Our goal over this next year has been really exciting. And I'm so blessed and so thankful that I was asked to do this lecture for you, because this is our goal over this year, is to bring at least our Boulder Valley back up to speed with concussion, right? We've been so bogged down with COVID, and the reality is our kids are back in school and kids are doing sports, which is great. People are active. So we need to do a revamp and talk about concussion again. So I'm super grateful. And that's what our goals are this year. What have we learned so far? Well, we've learned concussion doesn't go away. It's still there. Kids graduate, teachers go to different places. And so we need to keep on bridging. We need to keep on talking about concussion. We need to keep on having education about it, right? Coaches need education as well. And we have to speak the same language. It's really important because words have meaning, and those words carry significant consequences for our kids, our families, our teachers, and you name it. And again, once you've seen one concussion, you've seen one concussion. So if you are watching this tonight and you've never had a concussion, they showed me before that these are archived. At least hopefully you've learned something a little bit from this. One thing that you can go back to and say, oh my gosh, my niece or my nephew got a concussion. There was this doctor and she talked about concussion. Maybe I could remember something. We know that many times concussion doesn't matter for you until it happens. And the other thing we know is concussion programs work. We've been incredibly blessed with what we've been able to do here in Boulder Valley, in our school district and our partnership. And it's been really wonderful to see how we can affect the lives of our kids. So for me, one of my favorite new quotes is kind of my friend, Dr. Walt Disney. It's kind of fun to do the impossible. 9 years ago, we never thought that this was possible, that we could create a concussion program for Boulder Valley School District, and we learn as much as we did. And so I, again, have to put this wonderful list, and this is just a little piece of it, of all the wonderful people that have worked in this county to make this concussion program work. And we're going to continue to keep working it and learning more and more. And I'm just incredibly grateful for this opportunity to talk with y'all tonight. And I think I did it a little bit over, but I'm looking forward to questions now.
Thank you, Dr. Ballantine. That was very, very informational. We sure appreciate that. And we do have some questions for you, but we want to remind that our audience that they can ask their questions in the chat box to the right of the video right now.
Okay, great.
So I'm just going to dive in no particular order,
Great.
and we'll see what we can get through here. How long does a typical recovery take? Does it depend on the age?
Yeah, great question. It can be variable, anywhere from, like, I've seen kids in a week, they're better. I will say that if they try to push through, let's talk about kids first, is let's say 18 under. 18 and under can take anywhere, and it can be normal, so don't panic, anywhere from 3 to 4 weeks. That can be normal because their brains are young and they're developing. But some kids can get better in 7 to 10 days, so in a week they look tremendously better. So I would say for kids, in general, parents maybe set an expectation that this kid may take a little bit longer than they would like. When you add in those pre-existing condition and those concussion modifiers, it can take weeks to even months too. Yeah.
Okay. Is it true you shouldn't sleep if you have concussion symptoms?
Thank you so much. I should have put, that should be my myth. I should fix that. Thank you for bringing that up. Old school says no, please don't sleep, wake them up. Please let them sleep. Their brain is tired and they need to sleep. You should check on them. And like I said, make sure they're arousable and that they're breathing and all that, but let them sleep. They've got to sleep. That sleep is recovery. That's where they're going to get, part of where they're going to get better. So yeah, that's okay.
What would be too long to let them sleep? Would there be an indicator of that?
I've had kids sometimes sleep like 12, 14 hours, I mean, then their parents are checking on them, of course, So as long as they're sleeping okay, right, and they're not having funny breathing, they're not difficult to arouse, then that's okay to let them sleep. That's why they need to be watched, right?
Perfect. What are the long-term consequences of concussions?
I'm thrilled. I'd like to tell the story. Long-term consequences of concussion when they are not treated and people truly don't get back to their baseline, a lot of psychological issues, right? So I can't tell you how many people through the years have said, I just thought I was going to be stupid. And that just breaks my heart because it's not true, right? So the issue is if you haven't really been diving into your symptoms and you really haven't gotten back to your baseline, it can be a variety of different things. We'll see kids that didn't get their eye motion back, and so now they get labeled with a diagnosis of ADHD because they don't like to read anymore. And then they get their next concussion and you go through it and you find, gosh, they don't have their eyes. You fix their eyes and guess what? They can read and they don't have ADHD. So it can be improper diagnosis, improper use of medication. And I think the biggest risk factor is honestly mood, depression, anxiety, and just feeling like you're not back to yourself. And I think that's pretty significant.
Okay. This is specific for this person.
Yes.
They played football through college and had 3 concussive episodes that they know of.
Yeah.
They seem to be strikes from the side.
Yeah.
Is there a difference between hitting your head from front to back versus side to side?
It's a great question. I love it. So we have this torque and the inertia, and there are certainly some relationships that we see. Front and back concussions where you're going back and front here, a lot of whiplash. A lot of times side hits will also involve the TMJ as well. So it's not 100%, and you can't always say that when someone hit their head from a various place that you're going to have these symptoms. It can be quite variable, but certain mechanisms of injury are going to carry more whiplash, where some may carry other different things like I said, TMJ or other areas that are bothersome. So I think that's a great question, but it's still variable. Once you've seen one concussion, right, you've seen one concussion.
Is there a way to see if there's brain damage like an MRI or EEG?
It's a wonderful question. There is some lovely research going on for EEGs, qualitative EEGs, that are looking at that. There are functional PET scans, functional MRIs that we can use. This stuff is not anything that we can use yet in normal clinical practice. It's more on the research base. So years down the road, you can have an MRI and you can see little pinpoint places where someone has had trauma, very similar to what it looks like with migraine. So it's definitely something that is very much evolving and is very much part of the research and something that's important. But we don't have anything right now that I can look at and directly correlate to if you have this abnormality on this functional PET scan or this EEG, that it directly matches what symptoms you're struggling with. So that's part of the research for sure.
How are Boulder Valley School District teachers and coaches informed and trained about the concussion program you spoke about?
Great question. Pre-COVID, and we're working on this year, we did a lot of in-services. Our nurses get a lot of training with this as well. And then at the beginning of the school year, the teachers are getting education through all of their, in-service days and whatnot. We are actively working on that right now because we know that everybody needs that extra education reminder. Because to be fair, and I definitely have lived it this fall, we went from COVID to like that back to normal sports. And so it's definitely been a little difficult making that transition. And that's one of our goals together. And then actually with our coaches for Boulder Valley School District at our office, we just did Coaches Night Out, where we are standardizing the concussion education that our coaches in Boulder Valley School District get, which is wonderful. That's with our district athletic director, Sherrie Waterman. So we're really excited to bring that back as well, because that had gone away during COVID.
Would you recommend seeing a specialist versus your primary care?
Thank you for asking that question. Okay, here's the thing, right? So, your primary care doctor knows you the best, right? So when you start with concussion, what we really want to do is empower our family medicine physicians, our pediatricians with just a basic working knowledge of concussion, right? Because the reality is, right, most of these concussions are going to get better. So your family doctor, your pediatrician, your internist, they know you better. So they can say, oh man, Johnny's not acting right. Like I can see that. And then what we try to do is help them that if it's getting protracted and it's not getting better, that's when you grab one of us, right? A sports medicine doc that deals with this all the time. So the benefit of seeing someone that you know is that they really know you. And then you bring in the specialist when you need to. So obviously we're happy to see anyone, but the benefit of seeing someone that knows you really well is the fact that they can tell when something's off. So I think if your primary care physician feels comfortable with that initial step of concussion, it's absolutely the way to go. But if it gets stuck and you're not really back to yourself, then that's a good idea to get some help.
We have time for a few more questions, so we're going to get through these.
Okay.
2 years out of a concussion that caused short-term amnesia, still having symptoms of headaches, motivation, etc. Where do you recommend to get help?
That's a great one. Amnesia is a tough one. And it is one of the ones that's pretty well quantified in the literature that's a hard one to get rid of. And sometimes you never get that memory back. You need speech pathology, cognitive therapy, believe it or not. That's where I would go. And then those cognitive therapists, those speech pathologists are able to say, hey, I think maybe one of the reasons why you're having difficulties, maybe your eyes didn't come all the way back. So we need to do physical therapy with a physical therapy specialist that does concussion, as well as cognitive and speech therapy.
Kind of tagged on to that, with memory loss around the incident, how would loss of consciousness be noticed if it wasn't witnessed?
Say that again?
With memory loss around the incident, how would loss of consciousness be noticed if not witnessed?
We don't know. There's a code when we code this that it's uncertain if someone lost consciousness or not. So, and again, the reassuring thing in this diagnosis is that loss of consciousness, unless it was really protracted and really, really long, probably isn't going to make as much of a difference as the amnesia. The literature says amnesia is a more clinically relevant sign than the loss of consciousness. So I would be focused on that instead. So I sometimes will code the concussion with questionable loss of consciousness. So, but the nice thing for us is that loss of consciousness doesn't dictate the severity of concussion, and it doesn't dictate how long it's going to take you to get better. But the amnesia is predictive, can be predictive, as well as a high symptom burden when you first start.
A what?
High symptom burden. So if you have a checklist of a lot of symptoms, that's very predictive that your concussion is going to be more difficult to manage too.
So you've talked a lot, of course, about Boulder Valley.
Yeah.
Does St. Vrain School District have a brain injury resource team?
They do not. They do not have what we have the luxury of having, at least that I'm aware of. We do work with St. Vrain, and when our kids that are in St. Vrain, because we certainly have kids that are in St. Vrain that are here in Boulder County, when they have these concussions, we work very closely with NIWAT. We work closely, again, with the school district to make sure, and we use the same forms, we do everything. And so we just are differentiating to them. I'm not sure where they're at right now with what resources they have. We were very fortunate that when we got to do this 9 years ago, we got a grant to do this. So we had the right place, the right time, the right everything, which is pretty remarkable. But whether you're a charter school here at Boulder Valley or wherever you are, again, if you are interested or you think your school needs help, just reach out and we are happy to help you. We've gone to charter schools here in Boulder that didn't know what to do with concussion, and we've helped them. So again, this is like a nonpartisan kind of thing. This is for the benefit of kids, and there's no room for any kind of partisanship with that. It's just how can we help them?
So the same thing, besides your practice, how do you know if your doctor knows how to ID concussions? And
You ask them, just ask them, right? Just ask them. So do you feel comfortable managing concussion? Many family medicine doctors, pediatricians, internists will feel comfortable up to a certain point. Some of our Boulder BCH doctors are very comfortable with it, and we partner with them. And that's something, one of our goals again that we want to get back to doing is partnering again with our local physicians and empowering them to feel comfortable. So you just ask, just ask.
For brain rest, are you not supposed to watch electronics like TV, phone, as well as no reading?
Okay, so you ask like what I say at every first appointment. Okay, so you all have to listen because this question got asked. So this is what I describe. So my kids are little, and so just pretend that you have like the same age kids. They're 7 and 9 right now. And so they're walking home and they just went to a fun fair and they won a little goldfish, right? Y'all remember winning a goldfish, and the goldfish is swimming in all this water, right? And all of a sudden you trip and a quart of water goes out of your goldfish tank, right? And so then everything good that you do, like you do some rest, you wear sunglasses, you put a baseball cap on, that puts a tablespoon back of water back into your fishbowl. But then you spend a bunch of time on Instagram or TikTok, doing video games, really up close on a small thing. Now I take a cup of water out of my fish tank. So what you're trying to do is, I always tell everybody, you have one job in between the first and second appointment: take care of your fish. When you take care of your fish, you're trying to find the things that add to your fishbowl. So if you're trying to get better faster from concussion, probably sitting on Instagram and TikTok or whatever social media thing you want, playing video games for hours on end, it's not going to add to your fishbowl, is it? Going out and taking a walk could. So you do want to minimize. A lot of times things that are close up are really hard, so keeping things farther away, turning the backlight down, all that stuff is really important, especially in the first couple of days, week of your concussion. So that's a great question.
With a mild concussion, does ibuprofen help with swelling?
Oh, thank you. Another one. We're not talking necessarily about swelling in the brain, right? So we have an idea that we have concussion and it causes swelling, right? So when you read those international consensus guidelines, they're going to talk about this, a complex pathophysiological process, right? So we know that when it happens, there's massive neuron axonal death that happens. So you're not using the ibuprofen for that. You're using it to manage your headache symptoms that are coming because of the concussion. Great question.
We're going to squeeze in a couple of more.
Great.
And then we'll wrap this up. How dangerous are multiple concussions if they are years apart, followed by full recovery for each one?
Man, these are great questions. As long as those concussions are followed from the beginning to the end, and you do get back to your baseline, then you could just have bad luck and you could have 3 concussions. I didn't tell you this, and I should. Sometimes we have the talk, and the talk means you're done. You're done with football, you're done with skiing, you're done with high-risk sports. And that talk can happen at 1 concussion. I've done it in a Division I athlete where the concussion was just so bad, I had to say, no, you have to be done. I've done it at 9 concussions. So there's no one magic number of how many concussions are really bad. The biggest thing is making sure that each concussion is appropriately evaluated, followed from beginning to end, and then making sure that each time that you're getting a concussion that you're really being followed so that you can make sure that there's nothing that's lingering. So it's not really a great answer, but again, we're back to that individualized approach to the concussion. So we don't have a magic number yet. I don't know that we ever will, because each concussion is so different.
Last question is, have you gotten any pushback, or have you noticed if it's too much burden on a teacher to observe differences in a student due to concussion because of their teacher burden, especially with COVID now?
I mean, right. I mean, it's so hard for our teachers, and I've learned so much from working with the district. Another funny story is when we first wrote this 9 years ago, I took this policy home to my husband, who's an elementary school teacher. And I was like, oh my gosh, look at this great thing we're going to do. And he said the same thing that our teachers initially said to us. One, he didn't want to be played. Like he didn't want a student saying that they had a concussion and they didn't really. And I was like, oh my gosh, kids hate this diagnosis. That's very rare that anyone fakes it, because kids, right? Kids don't want to be different. Like they just want to like go with the flow and be the same. So that was a myth for them. And then they didn't want to do anything that would hurt the student. And the reality is that they can make symptoms worse, right? But they're not like hitting them on the head, giving them repetitive concussive blows. So we had to dispel those myths, and it is hard for them. But the reality is our job as a brain injury resource team and in the school is to teach the teachers that they do know. That's the thing, right? Teachers are amazing at differentiating for kids that have ADD, anxiety, learning disabilities, right? But we have to dispel the myth that concussion is somehow different, right? So if you have migraines, a teacher knows how to differentiate for you. But it very much has been a stigma and very much something that we've had to educate around. And we're going to be revisiting that again because it's been hard for the teachers, right? It's been hard on all of us, but teachers, it's been particularly difficult. So that's again on our goal of our revamp. I call it our facelift this year.
Thank you so much. This has been just a wonderful presentation, Dr. Ballantine. We want to remind our audience that she sees patients at CU Sports Medicine and Performance Center in Boulder. And we've come to the end of our time. A recording of tonight's lecture will be available at bch.org/livestream in a couple of days. You will receive a post-lecture survey by email tomorrow. Please take a minute to fill this out. Thank you for joining us and have a good night.